Sorry about that. Next up is Dr. Daniel Kass, also from the University of Pittsburgh Medical Center, speaking on lung manifestations.
Okay, so Dr. Gibson destroyed the microphone. Can you hear me okay? Okay. Thank you. You said oh, there it is, thank you. All right, so we don't want this microphone infecting people. So there we go. All right, so let me just adjust this a little. And I just want to introduce myself. My name is Danny Kass. I direct the Simmons Center for Interstitial Lung Disease. We were founded for a different disease. We were founded in 2001 for the disease called idiopathic pulmonary fibrosis, which is a disease of the aging population, and it's typically fatal within 4 to 5 years of the time of diagnosis. And so this was a very difficult disease to take care of, and largely because of Dr. Gibson, it rapidly became clear that the second most common referral to the Simmons Center is for sarcoid. And so roughly 29% of our patients have idiopathic pulmonary fibrosis, 27% have sarcoid. And I'd like to thank everybody. I see some familiar faces. I've seen some people that I've passed by in Dr. Gibson's office. We thank you for coming. We thank you for participating in all of our activities. And I have to say that the turnout today is really just so warm, heartwarming to see all of you, and to see that there's interest in fixing this problem. And part of what we do is research. And in order to do research, we have to engage our patients in research. It's all well and good to work on animals, but most of you don't have tails. And so while we can treat animals in a laboratory, we actually need to study human beings. And we thank all of you for participating. Okay, so what is sarcoid? Okay, Dr. Gibson showed this definition: the multisystem granulomatous disorder of unknown etiology, blah blah blah. Okay, the sarcoid in English. Okay, all right. So it's inflammation. What's inflammation? Okay, and it sounds simple. You know what inflammation is when you have it because it hurts. But say for example you fall down, okay, and you scrape up your arm. Your arm gets red, it gets swollen, it may bleed, it hurts. Okay, those are the classical signs of inflammation. Anybody here know Latin? So inflammation was characterized as having dolor, which is pain, calor, which is heat, rubor, red, and tumor, which is swelling. Okay, those are all the classical signs of inflammation. And so what is it about sarcoid? It's a particular pattern of inflammation that a pathologist will see under a microscope. And so Dr. Gibson showed the example of the granuloma. This is my picture of a granuloma. This is from a core biopsy. So this is a needle that was put into the lung and then pulled out. And this is and over here in this circle is what the pathologist sees and calls this a granuloma. Okay, so it's a particular pattern of inflammation. There are other patterns of inflammation that a pathologist will see, but this just happens to be the pattern in sarcoid. And something that a first-year medical student learns is that sarcoid can affect any organ system. Okay, and a medical student is presented with a case of a very unusual constellation of symptoms. And the medical student has to generate a list of possible diagnoses that can cause this. And the medical student is always right when he or she says, this could be sarcoid. And many of you know that. So some of you come to see me or to see Dr. Gibson, and some of you don't have lung disease at all. They said, you're coming to see us because you got a tattoo and the tattoo exploded, and or you have eye disease, or you have liver disease. And the fact is that sarcoid can affect any organ system. Pulmonologists are usually the first to see it because, and I'll show you the slide that Dr. Gibson showed, pulmonologists are often the first to see it because most patients have manifestations in the lung. Okay, so this is a study from Dr. Bachman, which was published in 2001 in the big lung journal. It's called the American Journal of Respiratory and Critical Care Medicine. And so this was a retrospective analysis where they looked at a community of patients with sarcoid, and they looked at 736 patients, and they saw that just about 700 or 95% had some manifestation in the lung. Now, that doesn't necessarily mean they had symptoms. They just had some manifestation in the lung. It could have been an abnormal chest X-ray. It could have been a cough. And I think they included people who had a chest pain syndrome that they included in the lungs. But you see that following behind it, it's skin disease and swelling of the lymph nodes. You see eye is very high up here. It's nearly 12%. But you can look. I mean, this is a list of your organs, right? Eye, liver, erythema nodosa is a particular skin manifestation, which I think we'll hear about later. The spleen is frequently affected. I've had a patient who came to me with a big golf ball on his cheek, which is a swelling of the parotid gland. It can affect the bone marrow. Patients have manifestations in calcium metabolism, which some may manifest as kidney stones. Anybody have that? Yep, you know that. That's the gift that keeps on giving. You got calcium. There's some people know there's sinonasal sarcoid. So you go see the ear, nose, and throat doctor for your recurrent sinusitis and those damn headaches, and you keep getting courses of antibiotics. And well, actually, it's sarcoid. Heart and down here, thankfully, bringing up the bottom is kidney disease. Okay. So I'm going to talk about a couple of cases, and it illustrates a lot of what we know about sarcoid. So here's the first case. A 26-year-old man was racing his ATV. This is the case I discovered out here. I'm from New York City. I didn't know what an ATV was, and I came out here. And he was racing, and he was thrown from his ATV, and he broke his shoulder. Okay, I'm saying what this has happened to the lung. Okay. He went to the emergency room and he got a shoulder X-ray. Well, the shoulder X-ray also gets a little bit of the lung. And the radiologist calls the emergency room doctor and says, yeah, your patient's got a broken shoulder, but his lung looks terrible. And so this leads to a dedicated chest X-ray, which we'll see in a second. And a similar case is a young woman, a 41-year-old woman, who was complaining of blurred vision. She was tired all the time. Every joint hurt. Okay, and she'd get up in the morning and everything was a struggle. She too had a chest X-ray performed as part of the workup. Okay, and I'm basically showing one chest X-ray, but these two patients are the same. Okay, and so this was a chest X-ray that the man had, but it's superimposable on the chest X-ray that the woman had. But what you see in this chest X-ray is kind of the classical signs. So here are what's called lymph nodes. Okay, and in particular, these are the hilar lymph nodes. Some of you may have heard this. If you've read your chest X-ray report, you say you'll see the word hilar lymphadenopathy, which means swollen hilar lymph nodes. Okay, and this is again a classical manifestation of that suggests sarcoid. It's not the only thing, and somebody who shows this X-ray, this person also had a lesion over here that looks like a mass. And so You get a chest X-ray for the first time, and the radiologist presents a reading, and now you can get these readings online. And you look at this chest X-ray, and this chest X-ray could be sarcoid, okay, which in the first cases, it was. But there are also other things on the list, and these things are potentially scary. And so many of you may have heard that you got this chest X-ray, and someone told you you might have lymphoma. Okay, anyone hear that? Yeah, a lot of it. These swollen lymph nodes could suggest lymphoma. These swollen lymph nodes could also suggest tuberculosis, and they could suggest sarcoid. In one case, it's cancer, and in another case, it's an inflammatory disease. And so, these are things that need to be answered and can cause a lot of anxiety when you first get this. So this guy who got thrown from his ATV was incredibly scared because he was out fooling around with his friends and made a bad decision, and he didn't expect to get diagnosed with cancer on the trip to an emergency room. So this was the diagnosis and not knowing the diagnosis can be scary for a lot of people. So what are the symptoms of pulmonary sarcoid? Okay, so again, this is a disease of a wide swath of the United States, you see that it's typically patients between ages 20 and 60. Okay, so this is a disease of younger Americans, and roughly about 50% of patients, it's discovered incidentally, like this guy, who broke his shoulder. Okay, so a lot of people have cough. Who had cough? A lot of people have dyspnea, which is the medical term for shortness of breath. People have chest pain, some have fever, some have malaise. Malaise is that, just not feeling well. Imagine you had a flu, but the flu lasted for 6 months. And some people experience weight loss. Okay. This leads to a chest X-ray, which this chest X-ray has, we borrow terminology from the cancer doctors, but this is, staging in sarcoid should not be, considered to be the same thing as staging in cancer. What these stages represent is the appearance of the chest X-ray, and it helps predict the risk of what Dr. Gibson was discussing earlier about chronic active disease or relapsing remitting course. So patients with a stage 1 chest X-ray are the patients who just have those swollen lymph nodes. Okay, and in those patients, we say that regression occurs in about 75% by about 3 years. Okay, so the stage 1 X-ray usually portends a pretty good prognosis. As you move to stage 2, you keep the swollen lymph nodes, but then you start adding in little nodules. And but still 2/3 undergo about spontaneous remission. When you go to stage 3, you get rid of the lymph nodes, but now you keep the nodules. Okay, and those patients tend to have less spontaneous remission. And then there's something called a stage 4 X-ray, which you may encounter patients who might need oxygen. Is that the nodules have really grown so close together that they kind of form big lesions, and that these lesions are centrally located. So they surround the large vessels and the large airways in the lung, and they can compress them, and it feels like you're breathing through a straw. And so this is a CAT scan. Just to orient you, imagine that I miniaturized myself. I jumped in your mouth, went down your throat, and I'm sitting in your stomach, and I'm looking up at the lungs. Okay? So again, we're looking up. This is your front, this is your back, this is the right side, and this is the left side. Okay? And what I like about, I don't know if it's reproducing well, but this is the point of the trachea when it divides into 2 large airways called the bronchi. Now these airways are filled with air. Anything with air on a CAT scan is going to appear black. Okay? And here's the right lung, and this is the left lung. You can see on the right lung here is there's lots of these little dots. Okay, I don't know if you can appreciate that. And you can see that some of these dots, this is the kind of wedge-like shaped area of lots of little dots that aren't here on the left. Okay, and these are micronodules that are typical of sarcoid. Okay, this is in contrast to a patient with what's called conglomerate central massive fibrosis. Okay, so now imagine all those little dots got more and more and more and more and more and more and more. And they all sort of got together, and what you see here is that this airway over here, okay, if we sort of cut it in moves, and that we see this airway again, but look at what's happened to this airway, okay? It's gone from this size all the way down to this size, okay? And so you can imagine that trying to breathe through a straw, or even worse, a coffee stirrer. Okay, and that's kind of what we see here. And I had this CT is from a patient of mine who was recently underwent a lung transplant. Yes, ma'am.
Are nodules the granulomas?
Is
that
yeah.
I like
yeah, but when they the question was whether or not the nodules represent granulomas. So short answer, yes. Granuloma is a microscopic structure, and when enough of the granulomas are close together, microscopically, they become something macroscopic, which we can see on an X-ray. So there are lots of the granulomas. Okay. All right. So why are patients short of breath in sarcoid? And so you can remember that sarcoid can do anything. And so patients with sarcoid are like a physiology lesson for students of lung disease. Okay, it can manifest with almost every potential manifestation of lung disease. Okay, so most patients with sarcoid have restriction. Okay, and I'll talk about what restriction is, but basically think about restriction of you decide that you want to go jogging one day. Okay, you decide you're going to get yourself a cute outfit. You bought the latest in the Nike, the Nike rainwear, and then you decided that you were going to take a tight-fitting belt and you were going to put the belt around your chest. Okay, that's what restriction is. It's restricting the ability of your chest to expand. Okay, and so you want to take a deep breath when you're running up that hill, and when you're running up this hill outside here, and you can't take that deep breath because your chest is restricted. Okay, there's something called obstruction. Obstruction is like asthma. Okay, and we'll talk about that. So think about again that you decided to get your outfit and you're about to run, and you take out that coffee stirrer, you stick that in your mouth, and you decide that you're going to run with a coffee stirrer in your mouth, and you're going to try to breathe through that. That's what kind of the asthma symptoms feel like. Then there's a much rarer manifestation called pulmonary hypertension, which Dr. Mathir will talk about in greater detail when he gets here. Okay. So who loves the pulmonary function tests? Come on. You come in, you pay us for the privilege, for have someone yell at you. Okay. And they stick you in a box, and if you're claustrophobic, it's not a terrific experience. So take a deep breath in, blow, 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 blow. Okay? So this is the restrictive physiology. Okay? When you do a pulmonary function test, you generate with something called a flow volume loop. Okay? And so this is the flow volume. This is a normal flow volume loop here in blue. Okay, down here. But here in red is what a restricted lung looks like. Okay, you can sort of get the sense that the area of the flow volume loop in a restricted patient is much smaller than it is in a normal patient. Okay, and so in restricted patients, the lung volume is decreased. They have decreased lung capacity, and the pulmonary function test shows low lung volumes. Okay. This is in contrast to an obstructed patient. Okay, so here's our normal flow volume loop again. And so, the lung volumes may be low. They could be normal, but they can also be increased. And what the problem is there is that patients who are obstructed can get air in, but they have a hard time getting the air out. So this is something you might hear experience as wheezing. So you take a deep breath in, and you breathe out forever. Okay, because what happens is the obstruction you feel is on the breath out. Okay, this is what asthma patients experience, or a disease called COPD. And so this is something you might get with you might get an asthma puffer. Okay, for patients with pulmonary hypertension. Pulmonary hypertension is an enlarged heart on the right side. So most patients, when we look at the heart, we look at the left side. Because that's the most common site of heart disease. But very few people look at the right side of the heart. And I don't know, I can't remember who it was. Someone described the right side of the heart as the Rodney Dangerfield of the heart. And said it gets no respect, but you discover it when it does. So this is an echo, and this is a picture of the right ventricle, okay? And this is a picture of the left ventricle. But what a cardiologist should know is that this image looks like it's flipped over, because the left ventricle should be much bigger than the right ventricle, okay? And in the patients of pulmonary hypertension, the right ventricle becomes very, very big. Okay, and the heart doesn't work well. And so this is a rare manifestation of sarcoid. But again, this can be a cause of shortness of breath. Diagnostic evaluation is a history, a physical, a chest X-ray, and pulmonary function testing, which includes something called DLCO. DLCO is you breathe in a known amount of carbon monoxide, okay? And we know what goes in, and we know what comes out. And if all the carbon monoxide stays in, don't worry, we're not killing you with the carbon monoxide. If all the carbon monoxide stays in, that means that all of it diffused into your lung, okay, which is what the lungs do. If all the carbon monoxide comes out, then there was something that prevented the diffusion of gas into your bloodstream, and these are patients typically with severe lung disease, okay? You might have a bronchoscopy, okay? There was a survey, guys, roughly about a third of you have had a bronchoscopy. This is what it looks like. We jam a long camera up the nose, okay, into the back of the airway and down into the lungs, okay, and you can take lots of little biopsies. Okay, these biopsies are about the size of a crumb, okay, and so we have to take several biopsies and try to get pieces of the lung. The best approach for getting sarcoid is to try to diagnose it in something that's accessible. So I'd much prefer a skin biopsy than a lung biopsy. But if you don't have any skin manifestations, then you got to go after the lung. Okay? And so you can get the bronchoscopy with something called a transbronchial biopsy. Some people have a needle aspiration where they'll use a bronchoscope and they'll sample some of the lymph nodes from the bronchoscopy. And then sometimes you don't get a diagnosis from that, and some of you have had a mediastinoscopy. So I suspect that some of you have scars right here from undergoing a mediastinoscopy where they did a surgical biopsy. Some of you have had ACE levels who've here, and did anyone get sent because their angiotensin converting enzyme blood levels were elevated? But my ACE level was high. Yeah, so a couple of you. All right. So the problem is that ACE levels are high in normal people, and ACE levels can be low in patients with sarcoid. So in fact, we don't use it. I don't think I've ever sent an ACE level, but this is something that's out there and that doctors will send, and then people come to me with an elevated ACE level but no symptoms, and it's very hard to convince them that they need to have prednisone. Okay, so the therapy for sarcoid. So corticosteroids, okay, and therapy for pulmonary sarcoid. So steroids are typically, we start with prednisone. Prednisone is fast, okay, it gets things under control. But for those of you who've been on prednisone, you know that it's a double-edged sword, okay? And I'll let you know that there's a lot of garbage out there. There's a lot of poor training out there and not knowing what the state of the art is for management of patients with sarcoid. I trained at an Ivy League institution, and I'm trying to show that off, but the point is that I trained at one of the big university centers, and I was taught that for patients with pulmonary sarcoid, for somebody manifesting that you treat them with 1 milligram per kilogram of prednisone. Okay, so an average human being is 70 kilograms, so that means you're giving them 70 milligrams of prednisone. Okay, and I had a lot of people come back later threatening me with bodily harm if I didn't do something quick. Okay. But it turns out that we can get a lot of patients under control with much lower doses of prednisone, and so you can do a lot in a lot of people at 20 to 40 milligrams a day to kind of get symptoms under control. The treatment for prednisone may last up to I try to start tapering the prednisone by 3 months, but sometimes it may last up for a year or more. Okay. And what has really revolutionized the treatment of sarcoid has been the addition of these other therapies. And so methotrexate is a medication that works slowly. Okay, it needs about 12 weeks to get into your system. But once it's in your system, that helps us get rid of the prednisone. Okay, and the nice thing about sarcoid is the nice thing about it is that Plan A doesn't work, Plan B may work. Okay, so if you don't tolerate methotrexate, many tolerate leflunomide, okay, or a medication called Arava. There are comparably fewer patients on mycophenolate or azathioprine. I have never given out Cytoxan or cyclophosphamide for this disease, nor cyclosporin. But a medication that we use a lot is something called infliximab, okay? And this is one place that I think the Foundation for Sarcoid Research could be very helpful in advocating for is making it easier for doctors to prescribe infliximab for patients who have not tolerated prednisone or methotrexate or Arava. This is it's an IV medication which we think is like the fail-safe mechanism to treat people. And so you got to decide whom to treat. Not everyone needs to be treated. Okay, some people just have a spontaneous remission, and in general, you treat the patients who are symptomatic. You're also going to treat people with other things. So if you have obstruction, where it sounds like you have asthma, you might actually do very well with asthma treatments. And so here's a little inhaler over here, and some of you may take the inhaler, and you may get a lot of relief from asthma treatments. For those with pulmonary hypertension, there are particular treatments for those patients called vasodilators, which Dr. Mathira may talk about in his talk. All right? And I think I will probably end there. I really want to thank all of you for coming. I want to thank the Foundation for Sarcoid Research for being an advocate for our patients and for spearheading all these efforts to try to build research and to make something of sarcoid. Sarcoid is understudied, and we need to come up with new treatments. We need to improve education of not only patients but also providers. Primary care doctors may be the ones treating these diseases, and I think it's important that we have high quality data to guide decisions. And I just want to thank everybody here at the Simmons Center. The Simmons Center, you see here, this is the Simmons Center staff. This is 30 doctors, nurses, research coordinator, PhDs in the laboratory, technicians, administrators, and all these people here are moved by the mission. Why does the person in the lab, slave in the lab over the lab bench trying to get something to work that hasn't worked in 6 months? It's that because they're doing it for the patients. They're doing it to try to come up with cures, to come up with treatments to make lives better. And so with that, do I have time for questions, or am I?
Hold it for the panel session.
All right, so save your tomatoes for then, and I'll be back. Thank you.